Good evening. My name is Samira Sadowski. I'm an endocrine surgeon at the National Institutes of Health. We would like to welcome everyone to this year's Neuroendocrine Tumor Awareness Month live webinar hosted by the American Association of Endocrine Surgeons, or AAS. This is in partnership with the North American Neuroendocrine Tumor Society, the Carcinoid Cancer Foundation, the VHL Alliance, the Amen Support Group, the International Neuroendocrine Cancer Association, the Neuroendocrine Tumor Research Foundation, and the FIO-PARA Alliance.
Hi, my name is Dhaval Patel, and I'm also an endocrine surgeon, a part of the AES IT committee, who is tonight's other co-moderator. We have assembled an expert panel to answer questions about neuroendocrine tumors, specifically pancreatic neuroendocrine tumors, and raise awareness of this disease. We'd like to thank the organizations for providing us with the questions by their memberships. In addition, we will be taking live questions from the audience through Facebook Live. Simply type your question into the comments section of the Facebook live stream.
We will start by introducing our panelists in alphabetical order by last name, who will tell you a little bit about themselves, their specialty, institution, and interest in neuroendocrine tumors. First, I would like to introduce Dr. Dillion.
Thank you for the introduction. So my name is Joseph Dillion. I work at the University of Iowa. I'm a staff physician there. I serve as the director of our multidisciplinary neuroendocrine tumor clinic. My background is as an endocrinologist, but I focus my practice entirely now on the care of people with neuroendocrine tumors.
Next will be Dr. Fahey. He's muted.
Hi, my name is Dr. Tom Fahey. I'm an endocrine surgeon at Weill Cornell Medicine and the New York Presbyterian Hospital in New York. I'm the director of endocrine oncology and the chief of endocrine surgery. My interest is in all endocrine tumors, but particularly in research. Our research interests are in pancreatic and pancreatic neuroendocrine tumors.
Great. Next will be Dr. Hughes.
Hi, I'm Dr. Marybeth Hughes. I'm Chief of Surgical Oncology at Eastern Virginia Medical School. I've had a long-standing interest in neuroendocrine tumors and as both an endocrine surgeon and surgical oncologist. So I do my own hepatobiliary as well, and so do both the primary resections as well as the liver work, and have a long-standing interest in a lot of different neuroendocrine tumors and familial carcinoid as well, as some of you may know. But I'm happy to be here, and I appreciate the panelists for putting this together for the AES.
Great, thank you. And next is Dr. Kunz.
Hi, good evening, everyone. My name is Pamela Kunz, and I'm a GI medical oncologist. I'm at Yale Cancer Center, where I serve as the director of the GI Cancers program. And my clinical and research focus is in the care of patients with primarily GI neuroendocrine tumors, but in addition, lung nets and paraganglioma and pheochromocytoma.
Great, and then last will be Dr. Solórzano.
Good evening, everyone. Thank you for joining us. I'm Carmen Solórzano. I'm a surgical oncologist and endocrine surgeon at Vanderbilt University Medical Center. My practice there is focused on endocrine, thyroid, parathyroid, adrenal disease, and neuroendocrine pancreas in the setting of multiple endocrine neoplasia and also sporadic disease. And I'm also, I think I said, director of endocrine surgery there and chair of the Department of Surgery. Thank you very much.
Great. Thank you for all of the panelists for participating. And we're going to begin the questions now. We'd like to remind the audience that you can ask questions in the comments section of the Facebook live stream. Please keep your questions as broad as possible, as we cannot answer questions specifically to individual cases.
And we'll start with the broad questions. What are pancreatic neuroendocrine tumors and how frequent are they? Dr. Kunz, would you like to start?
Sure, I can start. So as a GI medical oncologist, we think about pancreatic tumors in general. Neuroendocrine tumors are one of the least common of our pancreatic tumors. The pancreatic adenocarcinomas, or the more common pancreatic tumors, comprise about 95% of all pancreatic tumors. And less than 5% of pancreatic tumors are neuroendocrine tumors. They're different based on how the cells look under the microscope. So we rely very heavily on our pathology colleagues to help tell us that these are pancreatic NETs. And pancreatic NETs are rare by incidence, meaning the number diagnosed per year. It is probably about 1 per 100,000 patients are diagnosed with a pancreatic NET each year. The prevalence of all neuroendocrine tumors is actually increasing, as is the incidence. And the prevalence means the number alive at any given time. And I think this is a really important take-home point. Many patients with pancreatic NETs, particularly the grade 1 and 2 pancreatic NETs, can live for a long time with this disease. And I think that that's actually a very optimistic and hopeful, and I think has a lot to do with improved diagnostic, surgical, and medical techniques.
Great. So, Dr. Solórzano, what are the typical symptoms a patient with a pancreatic neuroendocrine tumor comes in with, whether they're functional, non-functional, and how do you counsel these patients on, the management?
So neuroendocrine tumors of the pancreas, nowadays we are finding many patients in an incidental way. We see them having some form of workup for something else. For example, a CAT scan for workup of a renal transplant or a kidney stone or something else that they are having a CAT scan for. And we find these round, very bright meaning they take a lot of contrast, IV contrast. And this is a very common way in which we're finding them. We also, so those patients have no symptoms. It's an incidental finding. And there are also patients who present perhaps with large neuroendocrine tumors that have, some of them may have metastasized to the liver. And those patients may have pain, perhaps from the liver or from the local tumor, a large tumor. In addition, we have patients who present with symptoms from production of endocrine hormones. One such tumor is the insulinoma, which produces insulin. It lowers your blood sugar. So the patients may have the symptoms of low blood sugar, which may include, some people may have seizures. Some people may just feel funny and do funny things and feel like their sugar is low. In addition, there's patients who may have gastrinomas, which produce large amounts of gastrin, which make the patient have diarrhea. They may also have ulcers and abdominal discomfort, bloating, etc. And those are the common functional tumors. So that's that doesn't cover all the types of functional tumors, but it's a start. And how to manage it was the other question. It depends obviously on the size of the tumor, how aggressive the tumor is, how advanced it is or not advanced, and whether it's functioning or not.
Great, thank you. We'll move to the next question. Dr. Dillion, how are pancreatic neuroendocrine tumors diagnosed?
Again, going back to Dr. Solórzano's point, pancreatic neuroendocrine tumors may come as functional or non-functional. As she alluded to, some of the non-functional ones may come into the clinic with abdominal pain, or maybe diagnosed incidentally. But actually, I think what you're getting at is how, once they come into the clinic, do we diagnose them? So non-functional tumors are diagnosed initially by imaging, I would say, with CT scan, MRI scan, sometimes ultrasound. The ultrasound is usually not enough to fully characterize them. They can be, they then need a biopsy to differentiate them from other nodules and lesions around the pancreas. They can also be diagnosed as neuroendocrine tumors by use of a PET scan, such as a gallium dotatate PET scan. The functional tumors present in different ways. People come into their internists with low blood sugars or stomach ulcers related to gastrin, or present to their gastroenterologists related to diarrhea. The functional tumors, those that produce hormones that cause these symptoms, in those people, blood testing is very important to initiate the diagnosis. So in patients who have insulinomas, for example, blood testing showing a low blood sugar associated with a high insulin level is characteristic of or consistent with an insulinoma, and would then that patient would then have imaging with CT scan or other scan. The actual blood testing for these functional tumors, blood testing alone, there are a lot of caveats within blood testing. Not all high insulin levels correlate with an insulinoma. Not all high gastrin levels correlate with a gastrinoma. So there is, it is important, I think, for a patient to see somebody who has a background in considering how to do these blood tests and how to interpret these blood tests. Blood testing alone in non-functional tumors is not particularly helpful. Those folks, as I mentioned, need imaging and biopsy.
Great. Thank you for that very detailed question. We actually have a question from the Facebook audience. And the question, this is actually addressed to Dr. Dillion as well, is that, can you describe what is a recommended fasting protocol for an insulinoma? Can you diagnose someone without the 48-hour fasting
Certainly,
test?
you can diagnose a person without the formal hospitalized 48 or 72-hour fasting test. If a person happens to have a low blood sugar while they are in the office, and that low blood sugar is associated with characteristic symptoms of low blood sugar, sweating, shaking, and a simultaneous insulin level, and we also do other insulin-related tests called proinsulin and C-peptide of insulin. If those are taken at the same time, along with a blood sugar that's less than 55 and the characteristic symptoms, then the diagnosis of insulinoma, the biochemical diagnosis of insulin-mediated low blood sugar is made, and you can proceed to imaging. However, for many people, they will not get hypoglycemia, low blood sugar. For 2/3 of people, it'll take 24 hours for them to get a low blood sugar while fasting. That goes up to, by 48 hours, it's probably 90% of people who have an insulinoma will get a low blood sugar. By 72 hours of fasting, almost everybody who has an insulinoma will get a low blood sugar. So it's not necessary to have a full 2 or 3 day fast in hospital, but it depends on how quickly how severe the issue is, and therefore how quickly the low blood sugar comes on during the daytime.
Great, many thanks. Dr. Hughes, we had another question. How do you diagnose patients with VHL and MEN1 when they are non-functional tumors?
Yeah, so I think this question is always a little bit tricky. So with the VHL patients, you know, they have standard imaging protocols that they should be following and being followed closely by either a pancreatic surgeon or a GI medical oncologist or somebody who can evaluate their tumors on a regular basis. And then there are criteria based on size, doubling time, things like that, and their mutation status in VHL that we use to try to decide on when surgery makes sense, when surgery is the most appropriate time for when they're risky and can start to metastasize, because the idea is you always want to try to operate on them before that time. With MEN, it's a little less scripted, at least in my opinion, and I can also get Dr. Fahey and Dr. Solórzano's opinion, but it's a little less scripted and a little bit more judgment. So you want to be with an experienced surgeon to be able to make those kind of decisions on when surgery makes the most sense. And I think that those are very difficult, and that's when probably you need the most experienced surgeons for those type of patients. You don't want to see somebody who doesn't have any MEN1 patients that they follow or any VHL patients. You want somebody who has experience with that type of patient population and understands kind of the nuances and the subtleties of kind of when they need what. And of course, a multidisciplinary format where you have your GI medical oncologist, you have your endocrinologist, you have all these people that you can do multidisciplinary tumor boards with and discuss these cases, because they're not always super straightforward. So I think that those are important factors and things that we consider every time we're dealing with MEN1 and VHL in particular. That was their main, yeah, that's my take on it. I'd be interested in Dr. Fahey and Dr. Solórzano to see if they had any different protocols that they use.
I would agree completely with Dr. Hughes. I think she, you know, kind of explained it very, very well. And I do agree that MEN1 patients do require some variability, and you do have to follow them very closely, especially when you're first seeing them, just to look at the time to doubling times and things like that. In addition, I think the history of the patient's family is, I always kind of consider to be somewhat important. So if a family member, a father or mother has died at a young age, I'm more likely to be a little more aggressive in that situation. I don't think we have the genotype phenotype, meaning the specific mutations in MEN1 quite as well characterized as they are, for instance, in VHL, to help predict when tumors may. Although Dhaval, maybe you can weigh in on that, or Samira, you may have new information in that regard.
So I would agree with everything that was said by Dr. Hughes and Dr. Fahey. I think that the way to describe multiple endocrine neoplasia patients, type 1 patients who have pancreatic neuroendocrine tumors, is that each one patient is very unique. And you cannot prescribe, you know, what you do for one for the other. There's some general themes, but that's how I kind of teach our residents and even our patients. small tumors, some patients will go for a long time with a small tumor in the pancreas and follow them and nothing will happen. And others, you have to take action, and some of them end up having a total pancreatectomy over time, not immediately, because they have numerous tumors in the pancreas. And then the functional tumors are also unique in that population. The VHL, I must admit, I don't see as many pancreatic cases with VHL, so I'll defer to other experts in the panel.
Great. So when you do decide to take action on pancreatic neuroendocrine tumor, whether it's sporadic, meaning that it's just found without a family history, without a genetic syndrome, or with a genetic syndrome like MEN1 or VHL, how do you decide what operation to do? Dr. Fahey, would you like to give us some insight onto that?
Sure. I think it depends. So deciding on what operation, it's important to consider the size of the tumor, the location of the tumor, and whether or not it's functioning. So for instance, a patient with an insulinoma that's localized and has no evidence for metastases on their preoperative imaging is amenable to a local resection and even an enucleation, because the percentage of those patients that ultimately prove to have malignancy is very low. Whereas a patient with a gastrinoma, I would be much less inclined to try to enucleate because they are frequently associated with lymph node metastases at the very least. So certainly the type of functioning tumor even will influence the approach. And then other things that have to be considered in terms of the size. So tumors that are larger are, first of all, going to be more difficult to just enucleate, particularly if they're in the head or the body, and will oftentimes be closer to the main pancreatic duct, which sometimes is even for a small tumor, determining factor as to whether a local resection can be done or a more definitive anatomic resection is required. And then finally, the location for any tumor, location is important. So tumors that are located in the head, and particularly more deeply in the head and closer to the pancreatic duct or closer to the bile duct are harder to consider an enucleation for. So even a benign tumor in that location may require more than just a local excision.
Great. We actually have another question from the Facebook Live audience, and it's very similar. Let's say you've had surgery and your margins are positive, or the surgeon says, I got most of it. What would be the next either follow-up or surgical options, Dr. Solórzano?
So I think depends on what kind of grade tumor we're dealing with. So if I say, okay, we enucleated an insulinoma and there was just a minor positive margin, I wouldn't worry as much about that. If you had a very large tumor and you did a Whipple procedure for it, and it's a low-grade tumor and your margin is positive, but it's at an area where you can't go any further with resection, then you may want to potentially watch that patient or use somatostatin therapy. It depends, but it depends on what that area looks like. So I think each scenario would have to be considered. But if it's a low-grade tumor, and obviously what I should say is that you should try to resect to negative margins. I should say that up front, that would be your goal. But if you do have a positive margin, I think that in a low-grade tumor, you can potentially watch that.
Could I add something to that?
Yes.
So, and I'll just comment also that from a medical oncology perspective, there's no known role or evidence to use chemotherapy following surgery. I think this is really an active area of research, and actually we will start working on a National Cancer Institute national cooperative clinical trial evaluating patients with high-risk pancreatic NETs and whether they should receive any sort of chemotherapy following surgery. So I think this is a really unmet need, and I think a lot of patients ask us questions about this, so stay tuned.
Good, thank you. And I'll follow up with you a question that usually is asked to surgeons, but what do you do in that gray area between 1 and 2 centimeter size? So size is important for, you know, indications for surgery usually. What do you answer to people asking, Dr. Kunz, when it's not yet reached that size?
Oh no, I'm not a surgeon. I probably shouldn't answer this.
I guess Dr. Hughes, maybe if she wants to chime in.
I would ask my surgeon.
Yes.
That's what I would do.
Yeah, I think that there's a lot of factors that go into deciding when to operate on patients. You know, fortunately, most of the neuroendocrine tumors in the pancreas are amenable to a biopsy. So the endoscopic ultrasound biopsy can help you determine grade and exactly what you're dealing with, because you don't want to be watching a 1 or 2 centimeter solid lesion in the pancreas unless you are 120% certain that is a low-grade tumor. And even then, in the sporadic setting, I personally have a little bit of heartburn watching them, because even low-grade tumors can go to lymph nodes and metastasize. So I tend to be, if the patient does not have a lot of medical issues that are prohibitive from a safe surgery, a laparoscopic surgery, a minimally invasive surgery, I will offer surgery even on some of those smaller lesions, because I think I can get them through it safely, and then I can get it before it metastasizes. Now, it's different when you have so that's a sporadic, and somebody with not a family history, no genetics. When you have somebody with the MEN1, VHL, it's a completely different set of criteria in watching people and small lesions. Those are okay to watch under very careful, experienced eyes. But I would say that most people that come in the door, I had one young man actually 2 weeks ago walked in the door, and another surgeon was telling him to watch it because they couldn't quite reach it with the endoscopic ultrasound. And even though it characteristically looked like a neuroendocrine tumor, I really have a lot of heartburn with that. So it's a very gray line. I know some people are very comfortable watching small lesions. I think if the operation is going to be a problem for you, then maybe watching is safer. But oftentimes I recommend surgery unless there's reasons not to.
Great. So when surgeons are offering surgery, what are some of the expectations and complications that patients should be prepared to face? Dr. Solórzano?
So obviously depends on the extent of the surgery you're going to perform, and for example, a minimally invasive laparoscopic distal pancreatectomy may be associated with potentially different risks profile than a Whipple procedure, total pancreatectomy, or an enucleation for that matter. So say a distal pancreatectomy might have some complications related to pancreatic leak. So whenever you cut the pancreas, the juices that the pancreas makes can leak. And no matter how great your surgeon is, this is an event that can happen. You suture up the pancreas, or you put staplers on it, and it still leaks. So an infection intra-abdominal in the abdomen that may require a drain. Also, patients in that could take several weeks to heal. The patients can have complications related to bleeding and infections. Whipple procedure can be associated with another set of complications, which may include leak, like I said, pancreatic leak, bleeding, infection, as well as troubles with emptying your stomach and loss of weight and diarrhea and a series of things. And then enucleations could be pretty straightforward many times, but not always. They also are associated with leakage of fluid from the pancreas and can have association of infections in the abdomen. So that's kind of a quick rundown of what it could happen. So we surgeons have a saying about the pancreas, and I'm not going to say the full thing, but it's don't mess with the pancreas if you don't have to, because the pancreas tends to, unfortunately, complications are something that is not uncommon.
Great, thank you. We had another question from patients, what to do after, well, how to follow after a completion pancreatectomy, and if the risk of metastases still exists. Maybe Dr. Kunz?
Sure, I'm happy to do that. And I think that, you know, surveillance or monitoring for metastatic disease is something that we do after a pancreas tumor is removed, neuroendocrine tumors included. Sometimes that's done by your surgeon and sometimes that's done by your medical oncologist. Typically, we'll get a scan following any sort of surgery for a pancreatic NET, and then often we'll do that annually for 7 to 10 years following that surgery. So for this person's question, we would still do that. Even though the pancreas is removed, the risk of metastatic disease is unfortunately not zero. And that's the whole purpose for doing the surveillance scans. The reason for that is that microscopic cells can escape from the pancreas, and the two main highways that cells spread through in the body are through the blood and through the lymph system. And so we typically will scan the body in areas that have a high risk for metastatic spread, and for pancreatic NETs, that includes the lymph nodes and the liver primarily.
Great. So let's say there is a patient with pancreatic neuroendocrine tumor and the patient has liver metastatic disease already, and it's already spread to the liver. Should we operate on that patient? If we do operate on that patient, what is considered a successful surgery? And should both the liver and the pancreas be operated on the same time? Would you like to chime in, Dr. Fahey?
Sure. So it's much of the decision there is individually based as well. So there's no kind of one size fits all for this. I think there is certainly depends on location of the tumor and extent of liver metastases and extent of what it would take to either try to do a complete metastasectomy or a complete removal of the metastases from the liver versus, so if you're talking about an anatomic resection, a formal anatomic resection, like removing half the liver, that's a much bigger procedure. And I would not recommend combining that with a Whipple procedure, for instance. These can be staged, and there's no evidence that there's any reduction in survival or an increase in recurrence by staging an operation in that fashion. If it's a smaller operation like an enucleation or a distal pancreatectomy, which can be done laparoscopically, then even a more formal liver resection can be attempted and can be performed. Certainly if you're going to just enucleate liver metastasis or a couple of liver metastases, I think that certainly can be combined with just about any pancreatic resection.
Great. Dr. Hughes, Dr. Solórzano, do you have other thoughts?
The only thing that I would add is that if patients have widely metastatic disease in the liver and they have functional tumors, we're always trying to do parenchymal sparing, meaning we're always trying to save as much normal liver as possible and getting rid of as much tumor as possible without costing them a lot of normal liver. And so when we do these kind of cytoreductive surgeries, we're always trying to combine, and I often combine modalities, meaning if it's on the surface, I can enucleate these the liver metastases. If it's a deep, smaller lesion, I will microwave ablate those lesions and kind of do a combination approach. I don't do a lot of big formal liver resections for pancreatic neuroendocrine tumor metastases because they don't tend to spread in just a lobe like a colorectal cancer. They tend to be more miliary kind of dots all over the place in the liver, and you just get as many of them as possible with sparing as much normal liver. And I agree completely with Dr. Fahey that these things, depending where the tumors are, how to combine them. If patients have functional tumors, I will often give them, or have my medical oncology colleagues give them long-acting somatostatin analogs first for a few months to get, sometimes you get a good tumor response, but you can control some of the hormonal symptoms and they get a little bit better going into surgery, and then plan their surgery. So there's a lot of different nuances to when they have liver metastasis and how to approach it. So it's, again, a very individualized approach to the patient, but I think you can get a lot of good cytoreduction. There's been some data that's, I think, promising for patients to have a more aggressive surgeon that's safe.
I would agree that with all the points that were made, and there's some nuances that I'm sure you all have dealt with, is when you do a procedure to remove the head of the pancreas, you connect the gastrointestinal tract with the liver ducts, and there's a problem when you treat the liver in those patients for their metastases, so they can get more infection. So there's some things that you have to think about in those patients, and the timing and the size and the amount of disease in the liver, how many metastases there are in the liver. Sometimes it's easy when you resect a distal in the pancreas, the tail in the pancreas, a lesion and a small lesion in the liver. That's an easy answer, but when you have a lot of liver disease and you have to perform a Whipple procedure, that's a difficult situation. And I think everyone does this, but we want to emphasize that this is multidisciplinary. Everybody has to weigh in. We have our trusty medical oncologists, endocrinologists, nuclear medicine physicians. Everybody looks at this and tries to come up with the best way to address it.
Great, thank you. For Dr. Dillion, a question, what's the most important prognostic factor? Something patients always want to know, kind of what guides us, such as, grade or other things.
In my mind, it's grade. And I'll echo Dr. Solórzano's last point about the importance of multidisciplinary group. Prognosis for the growth of tumors is something that I share those discussions with my medical oncology colleagues and the patient, as my medical oncology colleagues have I think a deeper understanding of tumor and cancer growth. So prognostic features, in my mind, it is grade. The grade 3, the poorly differentiated cancers clearly have a much poorer prognosis than the cancers that are determined to be well differentiated in grade 1 and 2, according to our pathologist. Other issues that would affect prognosis is really the degree of liver tumor burden is always is always something that's concerning, because the liver is a major prognostic factor in terms of how well people do. I'm sure Dr. Kunz would have an expanded discussion on that.
Sure, I can add a couple of points. I agree with what Dr. Dillion has said. I think that there's so many factors that go into our decisions to tailor treatments to specific patients, but I think that grade is really one of our first branch points. In addition to extent of disease, so is the disease localized to the pancreas, in which case all of our great surgeons who are on would really focus on surgically removing that tumor, versus has the disease spread to other locations. So those two things in my mind are probably the most important. I'll comment from the medical oncologist perspective. If I see a patient with metastatic disease, patients with grade 1 and 2 tumors, we generally lump together and treat similarly, and perhaps later we can talk some about those therapies. Grade 3 neuroendocrine tumors or neuroendocrine carcinomas generally are treated very differently with chemotherapy, as we worry that those are more rapidly progressive and aggressive tumors. So that's, from a medical oncology perspective, how we really separate those.
Great. We actually have another question from the live audience. And, maybe we're doing a great job raising awareness. So one of the questions is you have a young adult and they're asking, what imaging should we do for screening, or whether even we need to do screening for a neuroendocrine tumor? Dr. Dillion, would you like to answer that question?
Sure. I don't think there's any recommended screening for an asymptomatic adult without a family history or genetics that would suggest something like VHL, Vanhippolinda, or MEN type 1, or one of the other genetic disorders, tuberosclerosis, neurofibromatosis, that can be associated with a pancreatic neuroendocrine tumor. The actual, the incidence, as Dr. Kunz mentioned, is 1 in 100,000 people. So it's not a cost-effective proposition to have a screening test, unless there is some symptom or other important trigger to doing that sort of screening.
Dr. Patel, could I add something? So I'm wondering if that question was also getting at a little bit around if someone is around the surveillance. And so if someone had a known neuroendocrine tumor, and then we were, as I was saying before, talking about that monitoring period, I think for younger patients, I often will use MRIs to follow patients for those annual scans, as that has no radiation affiliated with it. I think there's, patients will often, I'm sure many of you have been asked about risk of radiation. So that is something I will consider. CT scans are also an excellent way of monitoring patients. And I think that the actual real risk to patients is quite low. I don't know if any of you also have other comments on the modality or type of scan that you use to monitor patients.
Yeah, I would agree with Dr. Kunz that MRI in the younger patient we tend to do, and CT scans are excellent also for if you're not as worried for radiation. And then I would add that we could say in the setting of multiple endocrine neoplasia, not just as it was said in a surveillance in somebody with a known tumor, in the setting of multiple endocrine neoplasia, probably we are going to do that more likely with MRI, because it's going to be a long haul for those folks, I think. So.
Great, that was for screening. Let's move to a part where patients also are very worried always is when we have advanced disease. And I guess we can address it to multiple of you all. What's the role of, for example, targeted chemotherapies, Dr. Kunz? We'll start maybe with you, such as everolimus, Sutent, and then we can maybe move later to Dr. Dillion for the PRRT, and then we'll open it even for surgery in advanced disease. We can open it up. So if you would all comment, please.
Yes, I'm happy to start, and I might just start broadly by talking about the kind of 4 broad categories of treatments we use for advanced disease. So one are the somatostatin analogs, so octreotide and lanreotide. The second would be real cytotoxic chemotherapy that gets a really bad rap, but perhaps we can talk more about that later, but those exist in IV and pill forms. The third would be the targeted or biologic therapies that Dr. Sadowski mentioned. So those would include Afinitor, also called everolimus, or Sutent or sunitinib. Those are pills that target certain tumor growth pathways. And then the fourth would be PRRT, which is the 177-ludotate or Lutathera that I can certainly let Dr. Dillion address. And so the good news is that in the last decade, we've had this explosion of clinical trials and new treatments available for patients with advanced disease. I think the real challenge right now is that there is no single best order in which we use those for patients. And so it really is tailored to the individual patient and what we're trying to achieve. So for example, the somatostatin analogs are often used first for patients with grade 1 and 2 pancreatic NETs because they are really well tolerated, tend to not cause many side effects, but they generally do not yield great tumor shrinkage. So that may be perfectly fine in some patients, but there may be some patients who have bulky disease or tumors that secrete hormones or tumors that are causing symptoms from being large, in which case we need to use treatments like chemotherapy that may shrink the disease. So maybe I'll stop there.
And just to echo that and bring it into PRRT, then in thinking about neuroendocrine tumors, something that's different than thinking about other non-neuroendocrine tumors, there are the group of neuroendocrine tumors that are functional, about 20% of them, and when they're metastatic, they're still functional. So many patients still have a lot of impact and symptomatology, not because of the bulk of their tumor, but because it's still secreting insulin and giving them low blood sugar, or secreting glucagon, giving them diarrhea, VIP, giving them diarrhea, or gastrin, giving them severe ulcer disease. So in terms of just thinking about the therapy of the secretions of these tumors, yes, getting rid of the tumors by surgical management and other options that Dr. Kunz mentioned, great, but we can also help with the symptoms with the octreotide or the somatostatin analogs, that's your sandostatin, your lanreotide. We can take care of symptoms related to gastrin by taking care of the excessive acid production that is produced there by omeprazole and drugs like that. There are other medications. One of the medications that Dr. Kunz mentioned, Afinitor, a targeted agent, is also very good at specifically decreasing insulin production. So the other group of medications or the direction of therapy is with radioactive somatostatin analogs. So these are essentially a radioactive form of the octreotide or lanreotide that people frequently take on a monthly basis. These tumors, most of them have receptors on their surface to which octreotide will stick, and therefore once the octreotide has a large quantity of damaging radioactivity associated with it, the injection of radioactive octreotide will stick on the tumor and cause death of significant portions of the tumor. Now, unfortunately, none of these treatments, apart from surgery for localized disease, is a curative treatment, and PRRT, as the radioactive treatment is called, is not a curative treatment either. But it's been a major advance in helping stabilize treatment, stabilize tumors, and in some cases shrink those tumors.
Great. This is a question for the surgeons on the panel. Let's say you remove all of the cancer and then it's come back and it's spread to the liver, or there's a small amount in the liver that you discover on imaging. How do you decide whether to take the patient back to the operating room, remove the tumor, or go with some of the medical treatments or PRRT?
I guess I can weigh in on that, but I think it depends on what you're talking about in terms of recurrence. If you just took out somebody's primary and they recur with liver metastasis, there's always a judgment there about taking them right back. Sometimes it's better to get your medical oncology colleagues involved, see if there's some systemic treatment that would be better for at least a time period to see if they're going to stabilize, you can shrink them, or they're just that's going to be the only disease. And then approach it either surgically or with what I call liver-directed therapies, which of course include a lot of different things that we really haven't covered much here, but can be anywhere from bland embolization, microwave or radio frequency ablation, depending on what your site has, bland embolization, or TheraSpheres or Suraspheres, which are radiation pellets to the liver. So there's lots of different things you can do if there's a recurrence to the liver, but it depends on the grade of the tumor. It depends on if it's just a small one area that then would be curative. So there's a lot of factors that go into deciding when to say when from a surgical standpoint, but usually a little tincture of time to make sure that's not just tip of the iceberg is the way to go. That's where I usually will use my gallium dotatate PET scan, because it's very sensitive. It can pick up things that aren't picked up on MRI, aren't picked up on CT scan. So it kind of tells a little bit more of the truth. It'll also tell you if you're hiding bony metastasis, which it's very good at picking up, that we don't usually see on conventional imaging, at least in my opinion. So it's a lot of different things that kind of go into when you reoperate on somebody.
And Dr. Fahey, how do you follow patients after you've had have performed surgery in general?
Well, in general, I think it's important to, I think imaging is the mainstay in terms of follow-up. You can also follow chromogranin A, which is a blood test. But imaging is probably the most important part. If they have a functioning tumor, you can then also follow the level of that hormone, and that's particularly useful for some of the rarer tumors, for instance, like a VIPoma, where you can use that as hormone as a tumor marker as well. And imaging is, again, I try to avoid the radiation when possible, so MRI or MRCP, and then dotatate scan.
Dr. Sadowski, can I make one comment on the one question I get a lot from patients is, should I be getting a dotatate PET CT scan every year? And I think it's controversial. I think we all use it to answer specific questions. But I will say it's probably not meant to be the routine method for imaging patients. I agree with many of the comments that were made that the conventional imaging, either CT or MRI, is probably our best routine tool to monitor patients, and then use the gallium dotatate selectively.
That's a good point. What are the follow-up, for example, after PRRT or such?
In many ways, it's the same sort of monitoring by imaging, with the same sort of imaging, indeed, MRI, occasional PET scan too, especially if there are specific questions, and in patients who have functional tumors, there can be blood tests to follow some of those tumor markers.
Dr. Sadowski, I saw a question from the Facebook live audience asking about TACE. If you don't mind, I'd like to address that.
Yep.
So TACE stands for trans-arterial chemoembolization. And it is a way where if you have a lot of different tumors in the liver that aren't amenable to surgical resection, or just ablations, which I like to refer as spot welding, then you can go up through the artery. So the artery preferentially feeds the tumor deposits in the liver. Whereas the regular liver depends more on the portal vein supply to be a healthy liver. And so we take advantage of that by going into the artery and kind of either just blocking the artery temporarily, which we call bland embolization, which is kind of using gel foam, which kind of clogs up the arterial parts of the flow to the tumors, and they really don't like that. And that's actually my preference for neuroendocrine tumors to the liver. The other chemoembolization, you can actually just put chemo agents into the artery, and then they preferentially feed these tumors, and they don't like that either. However, the side effects there are the side effects of the cytotoxic drugs. So whether those are changes in your blood counts or other side effects, they tend to have a little bit more pain associated with those treatments, nausea, vomiting, capsular stretch, and things like that. There are also radiation spheres, which are little tiny pellets that you can put into the arterial flow as well, and they get caught in the tumor. I tend to shy away from those in well-differentiated neuroendocrine tumors because I worry about the long-term side effects of the radiation to the normal liver, because these patients, God willing, live a good amount of time. So we do see those long-term side effects to the normal liver, which I don't like. And so I think that's probably in a nutshell. I don't know if Dr. Fahey or Solórzano have any other comments about that, but the other thing that's controversial is the radiation given to the liver in combination with Lutathera, because Lutathera is it's a radioparticle that's on the little receptors that go to the neuroendocrine tumors and attach and are what kind of kill that tumor. That's just what I would say in differentiation, but every case is different. I think these TACE type or liver-directed treatments are very good for functional tumors. They tend to knock down the hormone production significantly, and patients feel a lot better. You don't always get a great tumor response, but you certainly can.
Yeah, thank you for that answer. Unfortunately, it's already 9 o'clock. So we will have to finish that up. I thank you really all. I thank all co-panelists and also the AAES IT Committee Chairwoman Geeta Lal, who put all this together, the individual patient groups, and then the AAES leadership for allowing this webinar to be possible. And I wish everybody a good night. Thank you all.
So much. Good night.
Thank you.
Everyone.
Good night.
Right.